Hi, everybody. It's Susan Thornton with the Cutaneous Lymphoma Foundation, and welcome to our September Facebook Live interview. And tonight we have joining us Dr. Steve Horwitz, hematology oncologist, lymphoma expert from Memorial Sloan Kettering in New York City. Welcome, Dr. Horwitz. Thank you for joining us tonight.
Thank you.
Happy appreciate. Yeah, thanks for being with us. And we're taking a little different twist on the theme tonight and diving deeply into one of the newest treatments that we've had approved for cutaneous lymphoma, Brentuximab vedotin. And I know a lot of you have been either on this drug, or maybe we're part of the clinical trials, and now it's actually available for use for everyone. And it's a pretty exciting treatment for cutaneous lymphoma and for especially a little more challenging and advanced disease. So we wanted to bring you one of the experts that participated in the trial. Dr. Horwitz was engaged for the very long journey from kind of start to finish, and he will be sharing with you some background information and a lot of information about the drug itself, and then we'll open it up for questions after we finish with the presentation. So to get started, I'm just going to turn it over to Dr. Horwitz and let him take us from here.
Thank you. Thanks, Susan. Happy to be here. Yeah, I'm going to just walk through a little bit of background data on Brentuximab vedotin, which is one of our newest treatments for cutaneous T-cell lymphoma. I'll talk a little bit about overall treatment paradigms and just try to explain how some of us, or at least how I think it fits into the overall treatment paradigm, and then give you some of the actual clinical trial data that led to the big study, and then the big randomized study that led to approval. So to just get started, Brentuximab vedotin was initially approved in 2011 for systemic lymphomas, Hodgkin lymphoma, and anaplastic large cell lymphoma. And anaplastic large cell lymphoma is a subtype of T-cell lymphoma. It was much later, in just this past year, that we got final data for a large study in CTCL, and then that led to FDA approval, or an expansion of the label. Those are my disclosures, consultancies, research interests. We work with a lot of companies in terms of new drug development, and those are there for you to see. So just to sort of try to get us all on the same page, you know, in cutaneous T-cell lymphoma, by and large, we take what's called a stage-based approach, meaning your stage of disease largely dictates what kinds of treatments are appropriate, what kinds of treatments may be inadequate, or what kinds of treatments may be more than you need. And just so we're talking the same language, when we say early stage disease, we generally mean skin only, and usually an absence of tumors. So that's patches and plaques, or what we might call stage 1A and 1B. Doesn't mean you don't have a lot of disease, but when we say early stage, that's generally what we're referring to. People who have skin only disease, usually we prefer to treat with skin-directed therapy only. Skin-directed therapy, on average, has a little less in terms of side effects, at least overall side effects on your body, than systemic therapies or therapies you take inside your body through a pill or intravenous. And if the disease is only on the skin, often we can get away with skin-directed therapies, or if skin-directed therapies only, again, like creams or phototherapy, light treatments, are not adequate, we may add some milder systemic therapies. Once people have more what we call advanced stage disease, and by that we generally mean stage 2B, which means tumors, or disease outside the skin, which would make it stage 4. And that could be disease in the blood, or disease in lymph nodes, or even occasionally in organs. If you have disease outside the skin, then we really need to use systemic therapy as part of the treatment, because skin-directed therapies generally only treat the skin, and we're not getting at all the disease. I think the other principle we think about for cutaneous T-cell lymphoma is, for most people, the disease is slow growing, and that they're often something they're going to live with for a long time. So we try to take a long-term approach, and that means we're using treatments that either don't have an accumulation of toxicity where you have to stop, or treatments that are unlikely to have significant or life-impacting side effects. And of course, it's always a balancing act between how well a treatment is working. But by and large, our initial systemic therapies, and we'll talk about how Brentuximab vedotin data may change this a little bit, we usually would start with what we thought would be the mildest therapies, and those are therapies that you could be on long-term with little cumulative toxicity. And often that's things like retinoids, interferon, histone deacetylase inhibitors, or some types of immunotherapy, things like photopheresis. So when do we use systemic therapy? So Brentuximab vedotin is an intravenous therapy. It's given as an IV infusion over a half hour, 1 day every 3 weeks. That's the standard dosing. And again, we'll use a systemic therapy like that when people have earlier stage disease that has really been refractory or not well controlled to many attempts at skin-directed therapy. If there's things about the lymphoma that make us more worried that you're not going to have long-term control, that the lymphoma may progress more rapidly than average, and those are things in a biopsy that we might see, like large cell transformation, or sometimes what's called follicular tropism, or where the disease invades down along the hair follicle, you can get a deeper involvement. Or people who have truly advanced stage disease, meaning the disease is outside of the skin and inside the body. And those are cases where or systemic therapy would be indicated. Before Brentuximab vedotin, I used to think there were some basic principles of management when we lecture or talk about this or think about this. And that was that most of the systemic therapies had similar rates of response. I'll show you a table, I think, in a second that gives some overall response rates. But most of the treatments we use would have response rates of about 30 to 50%, meaning about half the people or so on a treatment might get significantly or completely better. Most responses, however, would be partial, meaning for those of you who've had treatment for CTCL, you know that most often when we treat this disease, the disease may get a lot better, but it tends not to get completely better. And most of the treatments we've had are used best or control the disease best when you're on the treatment, meaning they don't provide durable responses once you stop the therapy. And that kind of fits into this overall plan of trying to find therapies that we can use, the mildest, least toxic therapies we can use to control your disease so you feel well, but also keep you a well and healthy person long term. The one outlier to that sort of approach in the past was total skin electron beam therapy. This is a technique of giving radiation that just penetrates the skin to the whole body or all the skin. This has a very high response rate, but people can only get it once or twice during their lifetime if we give a full dose. So when it's given in full doses, that's usually about an 8-week treatment. And then you have to stop it due to accumulation of radiation dose. So this is just a table I made for a paper a number of years ago, but just comparing some of the typical treatments we have and the response rates. So bexarotene, which is targretin, vorinostat, which is Zelinza, denileukin diftitox, which was Ontac, it's not available right now. Romidepsin is Istodac. Those are all some of these milder systemic therapies that you can give relatively safely, long-term without accumulation of side effects, and those generally have response rates kind of in the 30 to 50% response rate. But the number of people who have a complete response, meaning their disease will get 100% better, is relatively low. When we would give stronger treatments or treatments like chemotherapy, and all these treatments down here are chemotherapies that tend to have a little more in terms of accumulation of side effects, the response rates go up a little bit. But you'll see, with the exception of this combination chemotherapy and radiation approach, the numbers are not dramatically different in terms of overall response rate or complete response than we get with some of the more biologic agents. And that's why, by and large, we use the biologic agents first. And people have made different paradigms. I'll show you something from the NCCN, which is the national guidelines we work on. This is just an outline of a number of treatments for cutaneous T-cell lymphoma, and it's just meant to show that people with really limited skin disease, it would be most appropriate to use skin-directed therapy only. When you have more generalized skin, we start with those, but if there's an incomplete response, you start to add in some of these biologic therapies. Eventually, if you progress through a number of therapies or a number of therapies don't work, we use things like chemotherapy. And then for people with really advanced stage disease, relapsed or refractory from a number of therapies, that's where we use things rarely like combination chemotherapy, more chemotherapies, or even sometimes think about stem cell transplant. So this is just another version of that, the NCCN guidelines, and we're modifying this so it will look different than this soon. But basically, we divide systemic therapies into something called Category A, which tend to be less immunosuppressive, milder, safer therapies. And if the disease dictates it, those are usually our first choices. When we progress through those or with more extensive disease, we'll use what's called Category B, which tend to be more like single-agent chemotherapies, and then maybe even progress on to more combination chemotherapies. In this old version, this was 2017 before the approval, Brentuximab vedotin was listed as a Category B. We'll talk about the data that's now moving it into what we would consider a Category A. So I'm going to go through the data now that led to the approval of Brentuximab, and hopefully I'll finish in time for plenty of questions. So the study that led to this was the phase 3 study called the ALCANZA study. A phase 3 study is a randomized study, and it was randomized against a control arm. There's very rarely placebos in oncology studies, and here the control arm was active therapy. Your doctor could pick. You would either get oral methotrexate, which is a standard therapy, or oral baxarotene, which is a retinoid, also called targretin. And patients would get randomized, meaning you or your doctor wouldn't get to choose. This study was really done around the world, and it was a very large study in a rare disease, and we really want to give credit to all the patients and really all the sites who participated, because this was really a worldwide effort among cutaneous T-cell lymphoma doctors to come together to try to generate this data. So just to explain to you what Brentuximab vedotin is what we call an antibody-drug conjugate. So an antibody is a protein. Antibodies are made by your body. They're part of your immune system, made by B cells actually, or plasma cells, not T cells. And what they are is proteins that may be specific for an infection like a bacteria or a virus. When you get a vaccination, you're stimulating your body to make antibodies against a specific infection. And then if your body encounters that infection, those antibodies would stick to the outside like of a bacterial cell and then recruit the immune system to fight that infection. You can also make antibodies against features on the surface of a cell. And this cartoon here is meant to show a cell. The DNA is on the inside, and the outside of all cells have a number of different features or surfaces or things that we call antigens. If you read your pathology reports and you see anything like CD4 or CD7, CD, that refers to one of these antigens on the surface of the cell. And Brentuximab vedotin is an antibody-drug conjugate where the antibody binds to something called CD30, which is on the surface of certain types of T cells, including fairly frequently cells of cutaneous T-cell lymphoma. And then what you do with this is there's drugs that are what we call naked antibodies. An antibody-drug conjugate really uses the antibody not so much as a therapy, but to draw the drug. And the drug could be a toxin, it could be a chemotherapy drug, it could be a molecule of radiation, but it draws the drug just to the cells that have the antigen or that the antibody binds to. And that's a way of giving potent therapies more specifically to the cancer cell, rather than other types of chemotherapy where we would give the therapy to the whole body and try to exploit selective killing of the cancer cell. This is a way of delivering the treatment directly to the cancer cell or just the cells that have CD30. So this is a diagram of how Brentuximab vedotin works. Again, it's an antibody that's shown in sort of this Y or inverted Y-shaped figure. The chemotherapy or the drug here is called MMAE or auristatin for short, and that's a chemotherapy, and that's bound to the antibody. You get this drug in the veins. The CD30 binds to the cells that have CD30, which are mostly certain T cells, including lymphoma cells. The cell then takes the drug inside. Inside, the cell actually cleaves the chemotherapy off of the antibody, and then the chemotherapy can direct its effect in the nucleus, injuring or killing dividing cells. So that's a way of really getting the chemotherapy primarily just to the inside of the cancer cell and sparing a lot of the side effects of the rest of the body. So Yun Kim at Stanford and Madeline Duvik at MD Anderson did some of the early studies. We participated in this study with Yun at Stanford, and it was just an early look at Brentuximab vedotin in mycosis fungoides. Now, we knew that Brentuximab vedotin was very active against lymphomas that always had CD30 on their surface. And again, those are things like Hodgkin lymphoma and anaplastic large cell lymphoma. But we also knew that people with mycosis fungoides sometimes had a little bit of CD30. And this was a study where any patient was allowed. We looked at how much CD30 you had, but even if the CD30 was very low or we couldn't see it, you could still go on drug. And those patients got treated with Brentuximab vedotin at standard dose. These are the numbers here. So it was overall 30 patients, a small sort of pilot or phase 2 study, but the response rate was 70%. So if you remember back to the other slide, this was a small study, but most of the drugs we use in cutaneous T-cell lymphoma had a 30 to 50% response rate. So there was a clue that this drug might be particularly active. We tried to look at if we could tell who was most likely to benefit, and this is sort of a complicated diagram, but basically it looks at CD30 expression on the bottom axis here. So people over here on the left, each triangle or circle or square represents a patient. People over here on the left had a very low amount of CD30, but 0% all the way over here. People over here on the right had a high amount of CD30. And if you are shown in blue here as a triangle, a square circle, you responded to Brentuximab vedotin. And if you're in red, you were a non-responder. Again, this was this small trial. And what we saw was that people, even with a very low rate, down to 5%, most of those people responded to Brentuximab vedotin. So that really suggested that maybe you don't need that much CD30 on the cell surface to be a good candidate for this drug. Once you got below 5%, the rates of response were lower. People less frequently responded. But if you look, there still were people responding at 5% or even lower. And right now, we don't know that there's a lower limit necessary to be a responder to Brentuximab vedotin. So those phase 2 studies showed really promising activity. There was a study from MD Anderson by Madeline and her group that I won't show you, but the data was pretty similar. And that really led to this idea that maybe we should really test this and compare it to some of our other more commonly used drugs. So this was the design of the ADVOCACY study. Often this is what we call a schema, and this is how we kind of show what the study, what happened on the study. So people who were eligible had to have mycosis fungoides with some expression of CD30. We weren't really sure what the lower cutoff was at that time, so we picked 10% largely arbitrarily. I think in retrospect, maybe we could have made that number lower. But in the ADVOCACY study, you had to have 10% of your cancer cells having CD30 to be eligible. Or you had something called primary cutaneous anaplastic large cell lymphoma, which is a more rare type of cutaneous T-cell lymphoma, but one in which all the cells have CD30 expression. You had to have had previous treatment with systemic therapy, so this couldn't be your first therapy to be on the study. And then if you were eligible and you agreed, you would get registered, and then you would get randomized, meaning a computer or something like a flip of a coin would tell you and your doctor whether you would get Brentuximab vedotin, this is intravenous every 3 weeks, or you would get one of the standard therapies, methotrexate or bexarotene. Now, because the Brentuximab is intravenous and because the standard treatments are pills, this was not a blinded study. So while we didn't get to pick what treatment people were on, we knew what treatment the patient was getting and the patients knew what treatments they were getting. And you could get treated for up to a year, and we would follow your disease and look and see how often people got better, how often they got completely better, and how long they stayed better. These are the people who were treated. So there were 60 or so people, 64 people in each arm, fairly even balanced men to women, and most of the people had advanced stage disease. So 2/3 of the people on the study had tumors or disease outside the skin. Now, I should point out here too that people specifically with Sézary syndrome were not included in this study. We don't have a lot of experience with how often people with Sézary syndrome are CD30 positive on their lymphoma, and while that data was sort of emerging when we first designed the study, people with Sézary syndrome were not included. Most people on the study had had prior treatment. Most people on average had 2 prior systemic therapies, meaning this was on average a 3rd-line systemic therapy for the patients on the study. This is something called a waterfall plot, and it tells you how who got better and how much they got better. Ignore the colors for a second, but basically if you start at 0, that's where your skin is at baseline. And if the bar goes up, that means that the disease got worse, or the way we measure the amount of lymphoma in your skin went up. If the bar goes down, it tells you that the disease got better. And if it goes down by 50% or more, we call that a response. If it goes down by 100%, we call that a complete response. And when we just looked at skin scoring, you can see most of the people, the bar went down, and the percentage of people whose skin got better on this study, 50% or more, was 80%, but almost everybody had at least a little improvement, and there were only a couple people whose disease really grew on study. When you look at the control arm, and this is methotrexate or bexarotene, most of the people also had the bar go down, but less frequently it went down by 50% or more, and the response rate in the skin was just 42%. So still pretty good and similar to what we've seen with other studies, but not as potent as the brentuximab vedotin. It was more likely on the control arm that your disease would get worse. Sorry, I'll move through. We then looked at an endpoint called ORR4, and one of the things that the FDA always looks at is safety and efficacy. So efficacy means clinical benefit, and clinical benefit doesn't mean you just got better if you got partly better for a very short time. So there's other measures of how long people got better for. And we developed this endpoint called ORR4 as the main endpoint of the study, and that meant that your disease had to get 50% better or more for at least 4 months or more. And we thought that was both improvement and some duration of improvement, that would correlate with benefit. And when we looked at that, in brentuximab vedotin, 56% of people got better for 4 months or more, while it was only 12.5% of people in the control arm of bexarotene or methotrexate. 15% of people with brentuximab vedotin had a complete response, not a super high number, but higher than we've seen with many other treatments for cutaneous T-cell lymphoma. And there was also a quality of life assessment, something called the Skindex, which is a questionnaire that assesses how much discomfort or how much quality of life impact there is from your skin. And that improved also more significantly for people getting brentuximab vedotin. The side effects, of course, are a major issue, and we think about a potent systemic therapy. If the side effects are too severe, the risks or the side effects may outweigh the benefits. Brentuximab vedotin's main side effect is what we call peripheral neuropathy. So as people get continual doses, there is a little bit of injury to the nerves, and that can accumulate over time, can maybe start as numbness or tingling in the fingers or toes. Those are the longest nerves in your body. And if it keeps getting worse, it can progress to discomfort, pain, numbness, or even what we call motor neuropathy, meaning weakness. Because this usually comes on slowly and we're watching it, we would almost always stop someone's treatment before they got significant neuropathy. But low levels of neuropathy are common, and on average on this study, people could get about 12 doses or about 36 weeks of treatment. And that was certainly more common in the brentuximab vedotin arm than in the standard treatments, which don't typically cause that. Other things like high cholesterol or high triglycerides are common with bexarotene, so those we're seeing, those are not side effects of brentuximab vedotin. And on average, if you look, the brentuximab vedotin, in addition to being a little more potent for the lymphoma, did have higher rates of things like nausea or diarrhea or fatigue, and mostly that was manageable or low grade, but more frequent than we saw with some of the other treatments. Sorry, I'll just highlight those there. So it looked like brentuximab vedotin was much more potent than the standard arms. We tried to do some additional studies to try to tell whether certain patients, based on their CD30 expression, would be really good candidates or super responders to brentuximab vedotin, or whether certain patients based on CD30 expression might be less likely to respond or less likely to have long-term disease control, and we weren't able to find that. So if we looked at whether your CD30 was more than 10% or less than 10%, really the results in terms of how often you got better and how long you stayed better were really superimposable, and no obvious difference there. So the results of this study was, this was the first report of a randomized phase 3 trial of cutaneous T-cell lymphoma against a standard control arm. There now is a subsequent one, which I think you'll hear about in another one of these sessions coming up. And brentuximab vedotin really looked convincingly better. More people got better longer, more people had improvement in quality of life. In terms of reduction of skin symptoms, and that led to a recent FDA approval of brentuximab vedotin for relapsed CTCL. I think in the label there is some description of CD30 positivity, but it doesn't specify a certain percentage. So where would Brentuximab vedotin fit? I'll just talk about this for a second, some of my thoughts, and then we'll take questions. I'd say for early stage disease, probably not right away. It does have a high response rate, but at least as it's currently given, you can't give this drug indefinitely like you could with bexarotene or methotrexate or interferon if it was working well. So sometimes for people with early stage disease, skin-directed therapy or some of the other systemic therapies may still be the right way to go. This is obviously an individual decision between you and your doctor. We're currently studying some lower doses of Brentuximab vedotin to see if we can find a lower dose that would still be active, but maybe have lower rates of neuropathy or development of neuropathy further down the road to perhaps allow people to be on drug longer. And that's an ongoing clinical trial that we're doing now. In terms of advanced stage disease, I think Brentuximab vedotin really performed best in people that had more thicker or nodular disease, people with tumors or lymph node involvement. And those are cases where some of the other systemic therapies looked weaker, like bexarotene or methotrexate, and the Brentuximab vedotin really had high rates of response rate. In terms of what CD30 level is important for response, we don't know that yet. We think that people who have some CD30 are more likely to respond than people who have no CD30, but right now there's no real threshold that we know you need to have in order for this drug to work. Sézary syndrome, not included in this study. We have very little data. It doesn't mean it couldn't work, but right now I think that's more of a clinical trial question because we just don't have much experience for people with Sézary syndrome. Neuropathy remains an issue. And again, compared to some of the other medicines that we give continuously, Brentuximab vedotin may be used more as intermittent therapy, meaning you might get some doses. If the neuropathy increases, you probably have to hold the drug. I didn't show you this data, but about 80% of people, the neuropathy gets better if you hold the drug. And if it gets better, you can retreat if the disease comes back. Mogamulizumab, I'm not going to talk about now. You're going to hear about that, I think, in another one of these sessions coming up in the next week or two. So I will conclude there. Hopefully that was clear enough, but I'm certainly happy to take any questions about this or other areas of CTCL. Thank you.
Great, thank you. Thank you, Dr. Horwitz. I think I always learn something as often as I see the presentations. That was really clear, and I think gives everybody a pretty good sense of how it works, how we got to where we are, and where it fits in the treatment kind of protocols. So I'm going to start off with a couple questions, and then I'll encourage folks to put in your questions in the chat box, and we'll let Dr. Horwitz answer them and try not to keep him too late. So this is actually a question with regards to preventing neuropathy. And this person thought it was apparently irreversible, but from my understanding and what you said, it really isn't, but it depends on the dose and how it affects people. So maybe you could talk a little bit about managing that and how do you know? And is there a point where it's irreversible?
And I would say it was reversible in about 80% or so of people, and we think with more time it will be reversible. But neuropathy can heal very slowly, and it can sometimes take months or a year or so to improve. The improvement is more reliable if you have low-grade neuropathy, meaning a little bit as opposed to a lot. It's something that usually first patients report. You might initially feel a little bit of tingling or numbness in your fingers or toes. Again, those are the longest nerves in your body, so you might feel the injury there first. I think sometimes what we've seen in some people is while in a drug causing neuropathy, it should be symmetric, meaning your whole body gets exposed to drug. So it's often in both hands and both feet. Sometimes people have like a pre-existing back injury, and maybe there's a little underlying nerve injury, and this might uncover that, and you might feel it in one leg or one area or another first. Typically, it might come after the dose and then would go away before the next dose. It might come back and go away. As long as it's coming and going in mild, you're not seeing an accumulation of nerve injury, we would keep going. If it comes and stays, meaning it's numb or tingly, we talk to you about how bothersome it is. If it's an annoyance but doesn't interfere with function, you can manipulate your keys, you can button your shirt. Those are kind of fine motor things we would look to. As long as you're functional, if the drug is working, it's a decision with your doctor. Is this worth the trade-off, and do we want to continue? Usually for mycosis fungoides, where there are other options for treatment, if you start to get functional impairment, meaning like you're having trouble with fine motor tasks, it interferes with things like walking or balance, we would like to stop the drug before that or at the first signs that that happens, so we can let that heal, so we don't leave you impaired or have to wait for it to heal to really be functional. Again, the less options you have for treatment, the more advanced the disease is, you might make a decision to push a little further into neuropathy versus stopping sooner, but it does tend to be cumulative. In terms of prevention, we don't really know that there's a way to prevent it. One thing that we'll look at is other reasons that people have neuropathy. Could be things like B12 deficiency, could be diabetes. There's some other illnesses that cause neuropathy. And certainly this can add to that. So you try to minimize or control those other things. Try to make sure things like B12 are up to date or are replaced. People have tried with, a lot of chemotherapies cause neuropathy. People have tried.
Oh. Oops. Did we lose Dr. Horwitz? Uh-oh.
Yes, Susan,
Mike?
It looks like we lost Dr. Horwitz's internet connection there.
Okay.
So do you want to talk about a little bit about what's coming up in the next month? We're going to be doing
I will, and you'll
mogamulizum.
try to
Yeah, I'll try
get
to
him
work
back.
Sure.
We'll try to get Dr. Horwitz back. Sorry about that. These things happen with regards to internet that we can't control. But just to let everybody know that we will be talking with Dr. Yan Kim next month about mogamulizumab, which is, as many of you know, was just recently FDA approved. And that is also a systemic therapy targeted more toward Sézary syndrome. So we actually are very excited to have two new drugs, one more targeted for mycosis fungoides and one more targeted for Sézary syndrome, but in more advanced disease. And as many of you know that have been living with this for a long time and perhaps have been on a number of the therapies, we haven't had much new in our toolbox in quite a while. So both of these new treatments are pretty exciting to have, and especially as they come out of the clinical trial setting and the physicians can learn more about how they work in individuals in a broader population of people with the disease, the better we'll learn how to deal with some of the potential side effects and how to manage those better, and how things can function. So the more time under our belt, so to speak, with these new treatments, especially post-clinical trial, the more knowledgeable we'll become and to better manage some of those things like neuropathy with Brentuximab. And I would also just say, with regards to the neuropathy, I think it's really important us as patients to make sure that we don't gloss over a symptom. If you're feeling, like Dr. Horwitz said, just even a slight tingling in your fingers and toes, you need to let physicians know. So you talk about and manage it and watch it and take care of it before things get to a point where it may cause more problems. And then it also sounds like if you have other kinds of perhaps an old injury or something with nerve damage, something in mind and to think about, as the drug may have some impact there. Mike, how are we doing?
So, Susan, we have not yet reconnected with Dr. Horwitz. I'm reaching out to him, but
Okay.
maybe one of the things maybe you can chat about for the folks at home is our 2020 campaign that's going on, and I'm going to dial into Dr. Horwitz by phone.
Okay, great. And then maybe we can just get him to answer some questions that way. I know we have a couple more here, and then we'll sign off for the night. So yes, for those of you who have been participating in our 2020 campaign, thank you so much. We really appreciate all of your efforts. And for those this year, where are we? 2018. This is our 10th anniversary, the 20th anniversary of the Lymphoma Foundation. We have been in official existence as a non-organization since 1998. So in celebrating 20th year, we kicked off a campaign earlier this month, which this month of September is Blood Cancer Awareness Month, and the 14th of September is World Lymphoma Awareness Day. So we thought that was a great opportunity for us to kick off our campaign, celebrating our 20th anniversary. And the idea was to have a number of our folks in our community contribute $20 and then ask 20 friends to contribute $20. And you don't have to have 20 friends contributing $20, but it kind of made for a nice campaign motto, so the 20-20-20. And you know, the idea that, there we go, I hear a bell. Not sure what that was. Technology is always entertaining.
Keep going, Susan. We have Dr. Horwitz coming back in. We'll be with you in a moment. Keep going.
Great. All right. So, so again, the 20-20-20 campaign is our efforts to raise funds so that we can bring you programs like this and do more things to reach more people around the world. And obviously, the more that folks are willing to invest in our capacity to do this, we can bring you more. So I invite everybody to go check it out and to join us, even if it's just to jump on and support one of the folks that has a page up and running for $20 or $10 or $1. It doesn't really matter. I think the whole impact is, you know, we're hoping that you'll invest in what we do and who we are and what we deliver, like things like this. All right, we're back. Uh-oh, now we can't hear Dr. Horwitz. We'll see.
Okay, so he can't hear you. So what we're going to do, Susan, is we're going to bring him in by phone.
Okay.
1 second. Let me just...
Sorry, guys. Hang in there with us for a minute while we figure out the technology, and we'll answer a few more questions. We almost got to the end without any technical problems.
Yeah. I got kicked off, and it wouldn't let me back on.
I don't know what happened. Oh, boy. All right, but here you are. So,
okay, sorry.
That's okay. We'll take you this way. That will work.
Yeah.
All right. Let's see. So here's our next question. Why is CD30 positivity no longer a prerequisite to use brentuximab? I think you talked a little bit about that. That was one. It's like a three-part question. Okay. So I don't know if you want to elaborate on that any more than what you've already said, but maybe re-articulate it.
Yeah, I think it's a treatment decision. The study included people with CD30 positivity, and we do look to that when triaging treatment. We do have experience in people who are CD30 negative who still respond, though the likelihood of that may be a little lower. So it's not an absolute requirement. I think the other thing we've seen over time is one biopsy showing low or absent CD30 doesn't mean that another biopsy from the same person might show a different level. So if you look hard enough, you can usually find some CD30 if that's the need to make the treatment decision.
Understand. Right, because the biopsy is only going to show from that particular sample, right? So if you have a biopsy from your left hip and there's nothing, you might have one from your right hip, and that could be.
Yeah, you're not all the same,
right? Right. Which is why we like to do a lot of different biopsies, right? To get a better picture. So that's the challenge. Okay, so what are the reasons it might be used in place of mogamulizumab?
Yeah, so I think there's the mogamulizumab data, which I didn't go into, that was just approved in August. So that's a very new drug. It's a monoclonal antibody. There is some overlap, but for the most part, the mogamulizumab was studied primarily in people with Sézary syndrome. The study did not include people with large cell transformation. So in some ways, the CTCL populations in these two studies are really quite different. So for instance, for Sézary syndrome or significant blood involvement, the data is stronger from mogamulizumab, both more data and higher responses. For people with nodular tumor disease or large cell transformation, more or better data with brentuximab. If you're in the middle and you sort of are eligible for either, then we don't have comparative of those two, but there's a lot of issues that, that would be an individual decision, but both may be appropriate. And as we know, for people with CTCL, often the treatments are not so much if, but when, and something you might use now or choose not to use now doesn't mean you won't come back to that down the road.
Which is kind of a nice, I was just saying while you were offline, I talked a little bit about doing the, Dr. Kim's going to join us next month to talk about mogamulizumab and how, these two drugs are really the first two systemic agents that have been approved in a long time. And we really haven't had much in the toolbox. And so now that they're actually approved and out of clinical trial, we'll be able to gather more data in a broader population, because the clinical trials tend, you have to be very, very focused and very narrow in who is on the trial so you can collect the right kind of data. Now we'll be able to gather a lot more data on a broader population of patients and compare and contrast, and we'll know more.
Sequencing, like once a drug's approved, in some ways, a lot of the understanding really comes after that, because as you said, when a drug is trying to get approved, you're trying to ask a very specific question, and there needs to be a certain amount of rigor in that study. Once it's approved and it's proven to be safe and efficacious, then the idea that we might use it in different situations and really try to broaden where it works, that's a lot of some of the clinical research, a lot of what we do, but you really do learn a lot about that after approval.
Right. Which is why, when people think about clinical trial, it's like that's one big piece, obviously, but then post-clinical trial, there's still a lot of research that needs to happen, conducted to collect more data so that we can refine and understand impact, long-term side effects, and especially in this disease, the kinds of combinations that might work that you do during the clinical trial period. So I'm very excited about having these two new drugs. Anyway, okay, so let's see. Okay, so yeah, I think your question with regards to one versus the other in mycosis fungoides or versus Sézary. Okay, here's our next question. Would you take this with methotrexate or instead of?
Yeah, I wouldn't take it with methotrexate. There's not a lot of safety data in terms of combinations. I think in CTCL, a lot of people are in combinations. When we're combining systemic therapies, my preference is that initially they're combined as part of a study. So if there's some unexpected side effects, we're able to recognize that. Now, to be fair, brentuximab vedotin has been combined with chemotherapy for Hodgkin's and for anaplastic large cell or other systemic T-cell lymphomas. So the likelihood that there's a bad side effect with methotrexate is low, but I don't think I would right now combine that off study. The response rates are very high, so I'm not sure there's a need to combine it to increase the response rates. What we do think about is sometimes would it be sequential, meaning if this drug has a very high response rate, but you have to stop it due to neuropathy or want to stop it due to worry of neuropathy, could you get the disease a lot better and then use a drug like methotrexate or bexarotene or phototherapy or something to maintain the disease under control, something without that cumulative side effect. And I think those are strategies with sequences that I think, going forward, we're going to understand a lot better. Whether or not you would use this instead of methotrexate, it's an individual decision. This drug had a higher response rate, but it is IV and it does have accumulation of neuropathy. Methotrexate had a lower response rate, but it's oral, and it's unusual for methotrexate to cause accumulation of side effects. So there can be liver damage, but that's low risk and over years. So it kind of depends on your individual situation, but I think it's certainly another good choice.
Right. Okay, here we go. Very highly of brentuximab because it helped get down from stage 4 to stage 2, but it's really expensive here. Oh, they're in the Philippines. Moreover, healthcare here does not cover it. You really have to shell out money for it. Is there a way we can avail of it for less? just as background, they spent $8,000 a dose and had 8 out of 6 US dollars. Yeah.
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 I think that's less expensive than it is in the US, but I think without insurance, it's tough. I don't know, I mean, unless you do, Susan, of a free drug program. This is a new drug. I don't think there's a generic on the horizon, at least anything I know about. So I don't know an answer to the cost. I mean, you may have some insights into that.
Yeah, this is, once things do get approved, there tends to be opportunities to do other kinds of compassionate use and different types of programs. A lot of times it depends on the country and the health system in the country, and there's a lot of, well, I would say red tape, but that's probably what it is, you know, to be able to do that. But I think the best option is to try to reach out to the company directly, or have a physician in the Philippines. If you're in a country that doesn't necessarily have this available and approved for use, then sometimes going directly to the company, there's an opportunity for some compassionate use in certain circumstances. But it's usually, you know, on an individual by individual basis, and a lot is the country itself and the health system and how those things all work, and does the company have the capacity and the legal rights to provide drug in that country. So I would just say, if you want to reach out to anybody, can contact us, and we're more than happy to try to put you in touch with the right people, and just keep trying, I think is the best thing we can do. Okay, so I'm on a lower dose of Brentuximab, had 60 infusions, 2 full doses, and 4 at 60%. They had TSAB, then the tumors came out. It killed the tumors and nodules in 2 weeks. Low dose is working, no neuropathy yet. CD30 positive. Toes and fingers tingle, but comes and goes. Patches are fading too much. So I'm not sure what the question is, but maybe seems like it's been very responsive. Maybe some of the more aggressive tumors,
Yeah.
not quite for the less intense.
We do sometimes see that. Yeah, the faster growing cells are sometimes, you know, more sensitive more quickly to treatments than the slower growing cells. So that may be what you're experiencing. Maybe there's a differential CD30 expression, that the tumors were high and the patches are low, and we sometimes see that in tumors or large cell transformation. So, I mean, I think it's a good response. You know, I think if we could pick, the tumors we want to get better, because those are the more dangerous lesions. Patches may fade over time, or possibly other skin-directed therapy could be added if they don't. But that treating and then lowering the dose or reducing the dose, I think, is a common strategy to try to extend the use or minimize side effects. And again, I mentioned we have a study where we're looking at starting with a low dose to see what kind of responses we get. And, you know, is there a dose where the neuropathy would be much less frequent? And that's something we're trying to understand.
Right, right. And then that goes back to the same kind of thing that, you know, if you can get the more aggressive disease under control, then you might be able to go off the systemic therapy and go on something maybe more topical and see how that goes, and, you know, kind of back and forth depending upon how the disease reacts. Okay, let's see. In the case of Sézary, are you able to catch it in earlier stages, and can you treat it so it stops progressing? All the people I've met are stage 4, which is...
Yeah, I mean, it's a little bit of a semantic situation, because to have Sézary syndrome, that means you have to have significant burden in the blood. And if you have significant burden in the blood, you're stage 4. So sort of by definition, Sézary syndrome is stage 4. There are people that have Sézary cells in the blood, but at a low number, that don't have Sézary syndrome. And in those people, if you find it, now you don't randomly look for Sézary cells, so there would have to be a reason you look. But if you did find it, there are treatments that can treat it, keep it low, and may delay or avoid the onset of Sézary syndrome. But it's a rare disease. There's not a screening test for it. So usually when we catch early Sézary, it's because we're looking at the blood for another reason, or there was a rash that prompted someone to think about mycosis fungoides, and then we find a little bit of Sézary cells in the blood.
Yeah. And I think that's one of the challenges for it's, and this probably isn't clinically correct, but in some of the ways I think about it, Sézary is, you're automatically stage 4. That doesn't mean that you progressed from stage 1 to stage 4. It's just that the disease itself, the way it's categorized within the realm of all the cutaneous lymphomas, is stage 4. But to me, I always think of that as sort of stage 1 Sézary syndrome. Because you don't kind of progress, right? But it's a more blunting disease.
Yeah, sorry. No, and the staging system wasn't made, to make patients feel good or bad or as like a punishment. The staging system is meant to convey information to your doctor so we can understand how to categorize your disease and how to treat it. And if, so it's not like, yeah, it's better to be early stage than stage 4, but stage 4 Sézary isn't untreatable. It just means that's the definition of how we convey that there's disease outside the skin, that the treatments need to incorporate the skin and inside the body.
Right. Okay, let's see. Is there research with use of medicinal cannabis for side effects? Oh, we're going to have to do some research on this because we get this question every time, and I don't know that there's any research, but.
Yeah, I think there's a lot of personal use, and I think there's a lot of anecdotes. And I think, what we see with our patients in the absence of hard data is that some people find that cannabis makes side effects more tolerable, whether it reduces itch or reduces nerve pain or just makes it more tolerable. I think it's hard to know. I don't know of any sort of big randomized or blinded data sets where people take cannabis or placebo and see if it's better. But we do see patients using it for symptom relief of all kinds. So it's at least commonly used.
Right. See, is Sézary an advanced stage of MF, or are they really separate diseases? Oh,
yeah.
Good question.
It's a biology question. I think for people that have really traditional Sézary, they're separate diseases. Those are people who tend to have what we call erythroderma, so diffuse red skin, not really discrete patches or plaques, not tumors, and have high burden in the blood. I think there's both differences in the way those cells look in terms of expression. They have different mutation patterns. They're probably from different cells. So I think in that case, they're really different. But we do see people that have typical MF that over time might develop Sézary cells later in the course of disease, or have Sézary and then get more typical tumors. So I think there are more pure forms that are different, but then there's a lot of stuff in the middle where there is some more overlap.
As always, a challenge in this disease because there's never a black and white answer to anything that we do. Okay, let's see. How much is too much Sézary cell counts, and when should you really be worried? At what?
Yeah, there's not a numerical answer to that. More is more, and what we worry about in people that have high burden of Sézary is that they'll be more symptomatic, or the disease could cause more complications to their health, suppression of the immune system, invade other organs, etc. So we would like to keep the numbers low. You don't tend to feel worse if you have 5,000 Sézary cells versus 1,000 Sézary cells. But if we keep the numbers low on an effective therapy, that gives us comfort that we're reducing the chance that you would get worse or get into trouble down the road. So we'd like them to be lower with therapy. But there's no absolute number that's a crisis. You're really basing it on symptoms, basing it on how well a treatment's working and things like that. The number isn't so critical.
Understand. When would you use it in stage 2B? So I'm guessing we're going back to Brentuximab now. When would you use it in a 2B?
Yeah, so that's a situation where we might use it early. In someone that has 2B with just 1 or 2 tumors, radiation for those spots is still almost 100% effective. So that's still usually our first line treatment for tumors. But in people who have multiple tumors who've had radiation or have multiple sites to where radiation may not be so feasible, Brentuximab vedotin has about as high activity as anything or higher. So that is a situation where I might go to it very early on in terms of systemic therapy.
That makes sense. Makes sense. All right. Mike, do we have
Yeah,
other questions?
let me give you one. Give you one by Audible here, an Audible pass. Let's see. What about mogamulizumab for stage 4 Sézary syndrome? Your thoughts on that? I know it's in advance of the next show, but somebody's looking for your perspective on that.
Yeah, I think the best data we had with mogamulizumab, or where it was most effective, was in clearing the blood. So the people with higher Sézary burden or Sézary syndrome really were the highest responders, and on mogamulizumab. And when we look at response by compartment, meaning we look at overall global response, but we also look at how often the skin got better versus lymph nodes versus blood. The highest response rates are in the blood. So I think that drug really, the early use of it is probably going to mostly be in people with Sézary syndrome, where it really does well.
Okay, all right. And what is considered a high burden in the blood?
So to have Sézary syndrome, you need to have 1,000 cells per microliter. That's highish burden. Below that, we would call it B1 or lower burden Sézary cells, but not Sézary syndrome. So 1,000 is sort of the lower end of higher burden, but there are people that might have 4,000, 5,000, 7,000, rarely much more than that. But those are the kinds of numbers we're talking about. If someone has mycosis fungoides and we look carefully in the blood, we might find 100 or 150 Sézary cells, and that would just be a very low burden of disease. You wouldn't even necessarily have to treat the blood in those circumstances.
Understand. Great. Great.
Okay, another audible. Is there more recent data showing a true number of transplants performed with their outcomes among Sézary syndrome patients? Because I think they saw the 2014, there was a report as of, sorry, I didn't have your ear on that, Dr. Horwitz. Let me read that again. Is there more recent data showing a true number of transplants performed with their outcomes for Sézary patients? I think people saw the last published report as of like 2014. So people were wondering if there's more recent data about the success rates of stem cell transplants among Sézary syndrome patients specifically.
I'm not sure. I mean, I know the Stanford data I've seen, though I don't know if that's been published yet or it's just been presented at meetings. We looked at some sort of a big national T-cell lymphoma, of which there were patients with Sézary. So I don't know if there's any big data sets that are a lot newer than that. I think transplant is a tough question to get data around because different centers do it a little bit differently. They select their patients a little differently. So I look at it more in terms of principles, meaning transplant is potentially curative therapy. There are people in whom it goes away and never comes back. However, there are plenty of people who get a transplant and the disease still comes back. And then, of course, there's significant risk with transplant. So I think right now it's still a pretty individual decision. And I think it's a hard decision to come to based on data like 30%, 40%, 50% of people are okay, because it's a weighty decision that you make with your doctors. So I don't know of any like really big definitive data sets that change any of those older numbers that you've seen.
Okay, we have just a few more, Susan. It sounds like Brentuximab vedotin is a great addition to the toolbox for CTCL. What else is on the horizon? Are there any other treatments or clinical studies in the works?
Yeah, there's a ton of new drugs being looked at. I think Brentuximab vedotin and mogamulizumab just both got approved. So those are late stage studies that led to FDA approval. But there's a bunch of ideas that are in earlier phases, but like early phase 1 or phase 2, so just trying them out. There's some what we call targeted therapies that interfere with certain pathways within the cells, PI3 kinase inhibitors, JAK-STAT inhibitors. There is immunotherapy, so there's data with T-cell immune checkpoint inhibitors, a drug called pembrolizumab or nivolumab, which are approved for other drugs. There's an immunotherapy strategy using a CD47 strategy, which rather than stimulating T cells to fight the cancer, stimulates macrophages. Those studies are just finishing up their phase 1 or early phase studies, and we are seeing some interesting activity in cutaneous T-cell lymphomas or Sézary, and there's 3 or 4 drugs that work on that strategy that are right now in clinical trials. So there's nothing else I think that's immediate. There's a microinhibitory RNA that's going to start a big study. I'm trying to think what else is there. A lot of stuff like in the phase 1-2 realm. There's no that I can think of big randomized studies that are about done or anything. Susan, can you think of anything that I'm missing?
Yeah, I think there's a couple early stage phase 3 studies, one beginning for topical Brentuximab, and then the Sologenics, the not the regular fluorescent light, which is very early stage. So I think there's a couple of things that are a little further along than some of the other systemic agents that are kind of, like you said, either phase 1 or early phase 2 and just starting to recruit.
Susan, I
But
can think of
that,
one. Oh, sorry, go ahead.
Go ahead,
I'm sorry.
Mike. No, go ahead.
I was just going to jump in. Denileukin diftitox is going back through clinical trials currently, isn't it?
Mm-hmm.
Yes. Yeah, that study must be pretty far along. We're not doing that one, but it's been open for a little while.
So that's on tap.
Yeah, and that's on tap. Yeah, I haven't heard much about that, to be honest. So we'll see. Just to let everybody know, I'll be attending the European Cutaneous Lymphoma Task Force meeting next week. So we'll have presentations from mostly Europe, but really all over. There's a lot of clinicians from around the world that will be presenting on a variety of topics. So we'll do our best to capture all of that and then present it in a way that we can share the latest and greatest and any new things that are going on. So stay tuned.
Okay, and just a couple more quick ones, and then we'll be done. Are you okay on time, Dr. Horwitz? We're just hitting the 9 o'clock. Okay, just a couple more quick ones. Somebody asked, let's see, a high count of Sézary cells. Could that mean the cancer, it's not actually Sézary? Could it be another type like TPLL?
I mean, TPLL is a T-cell leukemia. It can have skin involvement. There are some differences in the way the cells look. There's some differences in the markers and sometimes the mutations of the cells. So yes, TPLL, if someone had a white count of 50,000 or 80,000 or 100,000, that's more common with TPLL. That's uncommon with Sézary, but it's really a pathology distinction, and certainly all T cells in the blood are not Sézary. So that's something that can be tricky to sort out, but it's important to sort that out because the way we treat TPLL is quite different than how we treat Sézary.
Okay, there's a question. Is there any significance of CMV with Sézary, that virus? I'm not quite sure what they mean by significance. Maybe, is there any correlation, I guess, maybe, or any higher incidence rate, maybe?
Not that I know of. I mean, CMV usually, most adults in the U.S. have been exposed. It's usually under control unless your immune system is suppressed. So there's a number of treatments, immunosuppressive treatments we give that can result in reactivation of CMV. I'm not aware of CMV being implicated as the cause of Sézary, but there are some of these large sort of microbiome looks at looking at sort of all the bacteria and viruses in a person. But I'm not aware that CMV is causative, but it does go along with some of our more immunosuppressive therapies.
Okay. Any relationship between, and I'm going to really butcher this one, Mucha-Habermann's disease and mycosis fungoides? My son had the pleva in early life and now has mycosis fungoides. MUCHAH, yeah.
I'm trying to think how to wade into this one. So there are these T-cell processes that are more common in children, things like pleva or Mucha-Habermann. They kind of relate in adults. They're a little bit analogous with lymphomatoid papulosis. I don't know. I mean, we do see them sometimes coexisting in people, whether one's an unusual form of MF or whether one really changes into another, I think is unclear to me. Sometimes we see a clonal relationship, but our bias, and I just see adults, is more often that people who have those diseases and MF have analogous but not the same process, that one doesn't necessarily morph into the other. But there may be other people who know more, or people who deal with pediatric dermatology who may have a different take on that.
Okay. Denise mentions that Brentuximab vedotin has been wonderful for her. Low dose is slower but still doing its job. Somebody asked about how frequently Sézary spreads to other organs.
Yeah, I don't know if I have a number. I mean, it's in the blood, so it's there. People with typical Sézary don't usually have organ involvement. They may get lymph node involvement or small lymph node involvement. If the disease grows and is uncontrolled and treated unsuccessfully or not be able to be controlled, people can eventually get organ involvement. But often typical Sézary is skin and blood, and then minor lymph nodes. But it certainly can happen. There's no barrier from once it's in the blood for other parts of the body.
Okay, great. And the very last question is, what about IL-2, I guess that interleukin-2, I'm not sure, and IL-31, any current studies with those?
I don't know. Do you know this, Susan? I know people have looked at, there's been some IL-2, but I don't know if it's going on now, and I don't know about IL-31.
No, I haven't heard either of those. I'll keep my ears peeled next week. I know there have been some preliminary, in the lab looking at some of that, but not to my knowledge. I don't know that there's any particular clinical trials that have come into play for those particular areas.
Okay. Well, those are all the questions, and so thank you both so much. Susan, there was a question about how someone can contribute to the 2020 campaign, so maybe you can just mention that, and we'll be good to go, I think, here.
Sure. Yeah, the 2020, you can just, if you go out to our website and go just to the donate button, I think you can get to it from there. We have a page on the website, and if you have any trouble, just let us know. We'll point you in the right direction. And happy to let you know how to do that. So give us a shout and we'll figure that out. But it's on the website. So, but if you can't find it, let us know. That'd be great. Thank you for that. And thank you, Dr. Horwitz, for joining us tonight. That was really terrific. And I know that there'll be a lot of people. Oh, thanks, Mike. There you go. There's the 2020 stuff. I think there'll be a lot of folks that'll watch this now that we're done live, because it's such great information. I think, the presentation really set the stage for how the drug works, where do we use it, what are we learning, and I think it gives everybody, I hope it gives everybody a lot more hope that there's good things out there that can work for folks. So thank you so much, and have a really wonderful holiday. I know it's one of the high holidays. We're Yom Kippur, which actually started at sundown tonight. So really thank you so much for joining us. We really appreciate it. And we'll catch up with you somewhere along the way. So have a great night and take good care. Thank you.
Thank you.